Good afternoon. It's 4 o'clock in the afternoon and 5 o'clock in Singapore. Good afternoon, ladies and gentlemen. Okay, again, good afternoon, ladies and gentlemen. Um, I would like to welcome everyone to the 8th ASPA-FLEX webinar, Advanced in Pediatric Perioperative Fluid Therapy. Today the program starts at 5 p.m. from the Singapore time until 6:35, and then we will have the closing and the time for question and answer until 6:45. For the question and answer, we'd like everyone to do the question and answer in the question and answer block. At that time, the chat function is not ready. And for the poll, today we do not have the poll. And for the certificate of attendance, this will be sent to you automatically after you return us the poll survey, the survey of this meeting, and then we will automatically send your certificate of attendance to you. So the ASPA-FLEX webinar, the Advanced in Pediatric Perioperative Fluid Therapy. When we talk about the pediatric perioperative therapy, we cannot forget Professor Frederick Berry, who is the pioneer in the development of pediatric anesthesiology and pediatric perioperative fluid management. He's the one who identified perioperative iatrogenic hyponatremia with the use of hypotonic solution. He is the one who early advocated of balanced electrolyte solution for pediatric fluid resuscitation and also pushed to extend the advance in adult fluid resuscitation to pediatric practice. What are the advances in pediatric perioperative management? This will include perioperative fasting that today we fast the kids shorter, the endothelial glycocalyx and perioperative fluid therapy, intraoperative use of balanced electrolyte solution and glucose management, perioperative fluid and colloid resuscitation in non-sepsis and sepsis patients, intraoperative restricted or liberate fluid management that come to the last practice that they try to introduce to it in the pediatric population. And the very most advanced is the access of fluid status and fluid responsive that is very difficult to do in the pediatric population, and monitoring during fluid replacement and resuscitation, and rational perioperative therapy in preterm and neonate. Today, we have 4 speakers and we have 2 moderators. The first moderator is Dr. Felicia Lim, pediatric anesthesiologist from University of Malaysia Medical Center, Malaysia. And our second moderator is Dr. Serpil Özkan, who is a pediatric anesthesiologist from the University of Acıbadem, Istanbul, Turkey.
Sorry, I was muted. Try again. Okay, our first speaker is Dr. Sunirat Kongseripon from Thailand. She is a professor of anesthesia from the Department of Anaesthesiology and Critical Care, Siraj Hospital, Mahido University, Bangkok. She is current president of ASPA. She's also the chair of Pediatric Anesthesia Club, chair of Perioperative Intensive Care Club, the Royal College of Anaesthesiologists, Thailand. And she sits in the committee of the Society of Critical Care Medicine. And without further much ado, I'll welcome her to deliver her talk on the science of perioperative fluid therapy.
Thank you very much, Felicia. I'm sharing my slide. Oh, sorry a little bit for the delay. I'm trying to share my slide. Um, sorry a little bit for the delay. Signs of pediatric perioperative fluid management. This is the conflict of mind interest. This is the scope of my talk. What is the endothelial glycocalyx? The endothelial glycocalyx is the gel-like protein that lined on top of the endovascular membrane and in the inner surface of vascular lumen. And this is the subendothelial glycocalyx that did not have any protein. But if we give out the fluid, we go to the subendothelial layer here and cause a shedding of the endothelial glycocalyx. Endothelial glycocalyx is the key regulator of endothelial function and regulate vascular permeability. Damage to this glycocalyx, or we call glycocalyx shedding, can happen in the situation of hypoxemia, low perfusion, hypervolemia, hypoalbuminemia, and sepsis, and also in the environment of low protein in the plasma. Leaking of the microvascular membrane can have the fluid, both crystalloid and colloidal, leak out into the interstitial space and can cause tissue edema. The severity will depend on the glycocalyx shedding, glycocalyx permeability, patient pre-infusion volume status, infusion rate, and degree of vasoconstriction. Infusion of an iso-oncotic colloid into this patient will have similar volume expansion effect to a crystalloid fluid. Semi-synthetic colloid extravasates faster than albumin. Early repair of the glycocalyx usually take about 5 to 7 days, might improve the cell volume responsive, coagulopathy, and patient outcome. Plasma and external albumin are more effective than semi-synthetic colloid, such as haze, at preserving restore of the endothelial glycocalyx. Intrafluid administration for children undergoing surgery is the fundamental component of the practice. The most important is that all time the patient should be uremia, complication of late initiation or inadequate fluid resuscitation, such as can induce mitochondrial dysfunction, shedding of the glycocalyx, increased vascular permeability, multiple organ dysfunction, and failure and mortality. Anyhow, complication of fluid overload and continued hypovolemia, hypoperfusion in the pediatric population has been reported. Volume status and degree of dehydration should be evaluated in every patient before surgery. This can be mild in children coming for elective surgery, but severe in traumatized, volume depleted patients undergoing emergency procedures. We should have the thorough clinical assessment before any surgery and look for the severe dehydration status. If we know the current body weight of the patient, this can help us to predict how much the deficit the patient has. The examination could include mental status, capillary fill, mottling of the skin, presence of tears when crying, assessment of the fontanelle, urine output, and number of the wet diaper. This is the table showing the severity of the dehydration that will be talked thoroughly at the end of this webinar. Fluid resuscitation is important in hemodynamic resuscitation than hindbrain outcome. Fluid should be considered as drug, indication, time and amount, duration, toxicity, and accumulation. Important is that different fluid composition can impact rate, magnitude, or hemodynamic effect, microcirculatory perfusion, distribution, capillary leak, inflammatory response, and outcome. Fluid can divide into two types, crystalloid solution and colloid solution. For crystalloid solution, we can divide into major types, balanced and non-balanced crystalloid. The balanced crystalloid is the crystalloid solution that have the electrolyte solution close to the human plasma. For example, of the balanced crystalloid solution is the plasma-like stereofundin and linker-lactate or linker-allicate solutions. Crystalloid solution is cheap, clean, and had a long shelf life, easily distribute and excrete, with less accumulation, and should be the first fluid of choice for replacement and resuscitation, and should be the fluid for interstitial resuscitation. 0.9% normal saline is the non-balanced crystalloid solution with a higher sodium and colloid. This can cause dilutional hypercholemic acidosis. And apart from this, if we give it too long, it can cause immune dysfunction and decrease mucosal capillary flow and decrease renal blood flow, especially to the cortical part of the kidney. For a balanced crystalloid solution, we have to be careful to give a state linker solution very fast because this can depress myocardial function and cause vasodilatations. And for linker lactate solution, the lactate in this solution can interfere with the lactate assay. This is a concise clinical review about balanced crystalloid solution. In the preclinical research had demonstrated that saline can cause hypercholemic metabolic acidosis, inflammation, hypotension, acute kidney injury, and death. From the study in the operating room showed that balanced crystalloid solution can prevent the development of hypercholemic metabolic acidosis and may reduce the need for vasopressor. And in the critically ill patient, received balanced crystalloid solution had lower rate of complication, included acute kidney injury and death. For colloid solution, we have two types of colloid solution, that is natural colloid and synthetic colloid. For natural colloid, we usually not recommend to use the blood component for fluid resuscitation, not apart from antigen antibody and tally. Uh, this blood component can cause hypernatremia because of the high sodium component in that. For colloid solution, the complication that we can find, that is anaphylaxis, accumulation, and toxicity. For example, renal toxicity and bleeding that usually find in semi-synthetic colloid. For albumin solution, that albumin molecule represent about 60% of total protein in the plasma and is the major part of the intravascular oncotic pressure. Albumin has many physiologic properties and also be a part of endothelial glycocalyx. For external albumin solution, for external albumin solution, 4 to 5% isooncotic isotonic solution and also 20 to 25 hyperoncotic hypertonic solution for volume limited replacement resuscitation. Different composition with different manufacturer can happen with the albumin synthesis. Hypocalcemia should be considered in large amount of infusion. Allergy can happen with albumin uh, solution also and should not be given faster than 2 cc per minute because of least side effect on the kidney, liver, and coagulation function. Albumin solution should be the ideal colloid solution for pediatric patients. For about the 6% hydroxyl ethyl starch, it can reduce induce tubular cell swelling, create hyperviscosity of the urine, resulting in renal tubular obstruction, medullary ischemia. And this starch, large molecule of starch, can deposit in many organs in our body, especially the kidney and the liver for years. And if the patient has impaired this function, can have the decrease or failure of the function of that organ later on. Recently, with multiple studies, both in the critically ill and non-critically ill, show that hydroxyl ethyl starch can increase the incidence of acute kidney injury, renal replacement therapy, and mortality. Increased incidence of bleeding from inhibit one very band factor and platelet and should not be used in sepsis and septic shock patients. And how about the use in perioperative? This is the study in more than 1,000 patient children across European countries with the use of balanced and non-balanced hydroxyl ethyl starch. The results show that higher rate of adverse events was observed in the high dose of non-balanced hydroxyl ethyl starch, but they did not mention about effect on kidney function. This is an animal study giving the 50% per kilo of paste or gelatin or 20 cc per kilo of balanced solution in the pediatric animal model in 30 minutes. And then they sacrifice the animal within 1 week. But they show that they could not see any problem with the renal functions. And this is the human study in adult comparing balanced hydroxyl ethyl starch and 5% albumin for volume replacement therapy in the patient undergoing cystectomy with a randomized control trial up to 30 cc per kilo on day 1. They could not see any significant difference in any outcome. How about in the in vitro? They found that in this study, in 2012, they found that HASE decreased cellular viability of the renal proximal tubular cell, and giving HASE to the healthy rat 50 cc per kilo can induce acute kidney injury in 6 hours. This is a very striking study about prospective randomized trial just coming out this last year. They compare the imbalanced haze and also compare with the normal saline as a bolus dose in the high-risk patient coming for major abdominal surgery. For more than 700 of the patients in adults. The results show that uh, they used higher saline in the HASE populations, and with the HASE amount that they use is about 20 cc per kilo on the first day of surgery. But anyhow, they found stage 1 acute kidney injury higher in HASE, and also kidney dysfunction up to 14 and 28 days in the HASE patients, but they had a trend to have higher mortality at 28 days and 90 days. So the conclusion of this study do not support the use of HASE followed volume replacement therapy in these patients. And given HASE was lack of benefit for these patients, but additional harm, including increased blood loss, more AKI, and trend toward higher mortality after HASE applications. And this is the meta-analysis of the prospective randomized trial studying about the safety of low molecular weight HASE in the pediatric patients. They found that volume expansion with HASE significantly decreased platelet count, increased length of ICU stay, and might have adverse effect on the renal function. With the conclusion is that HASE is not recommended in pediatric patients. For gelatin is the solution that had a low molecular weight, about 30 to 40 kilodaltons. Gelatin solutions are considered to have no dose-related side effect, less harm to the kidney because of the low molecular weight, but they still can set deposit in the kidney the same as HASE and more allergic reaction, and also have the effect on the coagulation. And from my study, I saw increased AKI and mortality in the septic shock patient when they use HASE compared to albumin. Dextran. Dextran 70s is the water soluble, had the increased volume expansion higher than albumin and HASE and improved microcirculation. The disadvantage of dextran is anaphylaxis reactions, hypocoagulability, negative renal effect can have the renal plaque interfere with the close match and increase fibrinolysis. So HASE should not be used as the resuscitation fluid, especially in pediatric patients. Hypovolemia and underestimate blood loss was the most common cause of perioperative cardiac arrest in pediatric patients. The patient should have immediate resuscitation to restore circulation to prevent mitochondrial dysfunction with balanced crystalloid up to 10 to 20 cc per kilo. Safe colloids for plasma expansions should be considered in one with hemodynamic instability when crystalloid alone cannot have sufficient efficient uh, produce increase in plasma volume in the situation that blood products are not indicated and the patient still is fluid responsiveness. And we should consider early transfuse in preterm and neonate and sick children. Severe cardiac complication was also reported with aggressive bolus of colloid solution for example, hyperoncorticoid solution. For the little patients as preemie neonate or small infant, we should use infusion pumps uh, to prevent complication from over and under infusion. And we should consider extend monitor, for example, invasive monitoring with the aggressive fluid moiety, such as arterial line or central line. Also, when giving the fluid to the patient, we should have continued evaluation for fluid responsiveness, adequacy of fluid and hemodynamic resuscitation, and complication of fluid resuscitation, either under resuscitation or over resuscitation. And also, we should monitor including macro circulations. For example, blood pressure, heart rate, pulse pressure, capillary refill, urine output, peripheral and central temperature. And we should also monitor for the microcirculation, especially in the aggressive resuscitation and in sepsis patient. For example, blood lactate and SCO2, end-tidal CO2 and meals. And we also have to monitor for complication of fluid overload by using chest X-ray, B-line lung ultrasound, or abdominal pressure. Hemoglobin coagulation, acid base status, potassium and calcium should be monitored also. Anyhow, we should know that when we should decrease or stop resuscitation. And for the sick or aggressive resuscitation, we should consider continuing care to the post-operative period or place the patient in the intensive care, especially in the preemie neonate or sick and septic patient. And also we have to careful about transportation also. This is the rationale for the perioperative fluid therapy in preemie patients. Preemie and neonate are vulnerable patients that prone to have complications from either under or over fluid therapy. They have the immature cardiovascular function and larger amount of fluid and insensible loss, especially when we use the radiant warmer during surgery and especially in the abdominal surgery that they can lose a ton amount of the fluid. And they have less glycogen storage with a high incidence of hypoglycemia. We should have adequate IV access in complicated case, adequate and consider invasive monitor in the complication case also. Early replace glucose, insensible loss, colloid and blood loss. We should use infusion pump to prevent complication. If we give a lot of fluid, we should be aware about heart-lung interaction with aggressive therapy. In conclusion, perioperative fluid therapy is the main perioperative treatment in children. Try to prevent shedding of endothelial glycocalyx is important, which is the controller of the microvascular membrane, such as try to prevent hypoxia, hypervolemia, or hypoalbuminemia. Balanced crystalloid solution should be the first fluid of choice for fluid resuscitation. Safe colloid should be considered when crystalloid could not meet or maintain hemodynamic with large amount of crystalloid. Frequent evaluation for fluid responsiveness and the responsive of the treatment. Continue look for complications and early glucose and blood transfusion should be considered in preemie, neonate, and sick children. Thank you very much for your kind attention and sorry for a little bit delay.
Thank you, Dr. Sunirat, for the talk on the science of perioperative fluid therapy. And our next speaker is Dr. Runrong Lelaknukrom. He is a professor in anesthesia from the Faculty of Medicine, Chulalongkorn University. He's also the Deputy Director of King Chulalongkorn Memorial Hospital. He's a President-elect of the Royal College of Anaesthesiologists of Thailand, and he sits in the board of Pediatric Anesthesia Training Thai Medical Council as the president. I would like to invite him to deliver his talk on pediatric perioperative fluid management principle and current consensus.
Thank you very much, Felicia, for your kind introduction. Good afternoon, all ASPA friends, ladies and gentlemen. First of all, I would like to thank the ASPA to let me have the opportunity to be here to meet our ASPA friends again in the pandemic crisis around the world. I'm very honored. My topic will focus on intraoperative fluid management rather than perioperative fluid. I have to declare that I have no conflict of interest. When we talk about the intraoperative fluid management, there are two issues that should be considered. Firstly is the volume. The objective of intraoperative fluid infusion is to maintain normal physiological state and homeostasis. The secondly is the components. The mainly are glucose and sodium. Glucose is the main substrate for energy production, brain metabolism, and reduced protein catabolism and sodium losses. However, both hyperglycemia and hypoglycemia are harmful. Hyperglycemia can cause osmotic diuresis, electrolyte disturbances, and increased risk of hypoxic ischemic CNS damage. And hypoglycemia can cause permanent brain damage. This comes to the dilemma of glucose administration. Withholding glucose can prevent hyperglycemia, but at risk of hypoglycemia. Wherever administering glucose can prevent hypoglycemia, but at risk of hyperglycemia. So the rationale should be administer glucose to prevent hypoglycemia and avoid hyperglycemia in the same time. What about in children? Hypoglycemia in fasting children. Children are the population at risk of developing hypoglycemia because of limited glycogen storage. The definitions of hypoglycemia ranges from 2.2 millimole per liters of 40 milligram per deciliters up to 3.3 or 3.5 millimole per liters or 60 milligram per deciliters. This number, most people think this is maybe too low. This is the studies on hypoglycemia in fasting children. If we consider hypoglycemia at glucose level of less than 2.2 or 40 milligram per deciliters, there is no instance of hypoglycemia. If we consider as 2.8 or 50, the instance can be up to 2.5%. And if we consider as 3.5 millimole per liters or 60 milligram per deciliters, the instance is as high as 7.4%. However, these studies are performed before the year 2000. If we look at that time of fasting, the fasting period of clear fluid is about 3 or 4 hours in children. This is the latest study of intraoperative hypoglycemia in children published in Canadian Journal of Anesthesia 2020. This is a large retrospective cohort on 70,715 children who have intraoperative glucose determination, and hypoglycemia was defined as blood glucose level of less than 3.3 millimoles per liter or 60 milligram per deciliter. The incidence of hypoglycemia was 3.5%. Apart from this, 20% of the hypoglycemic events, these children were also receiving glucose. However, there are some limitations in the studies. Only 10% of population of 77,700 in 73,000 cases were measured. There was also a selection bias. There is no reason recorded why blood glucose was measured. Maybe glucose level was measured because the anesthesiologists have some query about hypoglycemia, and also there are no exact time duration of fasting or the exact dose of glucose administration were recorded. Anyway, no matter what the study is, we have to admit that intraoperative hypoglycemia does exist, and the incidence was up to 7% or 3.5 millimole per liter if we consider 5 millimole per liter or 60 milligram per deciliter as hypoglycemia. So the rationale for glucose administration is to administer glucose just about to prevent hypoglycemia and avoiding excessive hyperglycemia. Now come to the next question. What is the appropriate glucose to be administered? Should we consider in concentration or in amount in a certain time? When we talk about the concentration is the ratio between the amount of the solute divided by the total volume of the solution. Most guidelines recommend intraoperative glucose solution should be administered at 1 or 2.5% of glucose. My recommendation is to focus on the amount of glucose rather than the concentration of glucose solution. The reason behind this is if we consider volume replacement intraoperatively, there are mainly in two parts, maintenance part and replacement part. If we give the same concentration of glucose with a whole lot of fluid, and most people give glucose solution as a maintenance and fasting deficit replacement, this will, which the volume is vary, this will give us a vast amount of glucose dose in children. So we should pay more attention on the amount of glucose rather than the concentration of glucose. Moreover, in some countries, such as in Thailand, where 1% or 2.5% of glucose are not available, we can administer 5% glucose solution in a reduced dose. So this is like this emphasize again that post administration should be considered in amount rather than in concentration. So when the amount of glucose in most studies were taken into consideration, the appropriate amount of glucose recommended is 120 up to 250 or 300 milligram per kilogram per hour or 2 to 5 milligram per kilogram per minute. This will give us the dose of glucose to prevent hypoglycemia without causing the excessive hyperglycemia. Also, the latest German Society recommendation in pediatric anesthesia in 2017 They recommend 1 or 2% glucose in a dose of 10 ml per kilogram per hour as a background infusion. The dose of glucose in this guideline is actually the same as this recommendation, which is about 100 to 200 milligram per kilogram per hour. This recommended dose of glucose can be applied in most cases. However, there are in some special group of children who are at risk of hypoglycemia. In this group of children, glucose should be administered at a higher limit because they are at risk of develop hypoglycemia, and blood glucose level should be determined intraoperatively. The other component of fluid is sodium. Sodium is the major electrolyte in the body that determines fluid shifting between inside and outside cells. I come back to this slide again. The hourly fluid intraoperative fluid replacement is fasting deficit replacement, maintenance fluid, and ongoing losses. Fasting children have a fluid deficit. During current fasting guideline, we allow the clear fluid up to 2 hours before surgery. Hence, the fasting deficit is less than in the past. In addition, what we didn't consider is the physiology of fasting during sleep, in particular fluid conservation during sleep, which under the influence of hormones, especially antidiuretic hormones. Apart from this, the activity during sleep was less than daytime. This means that fasting during daytime and nighttime do have the different on fluid replacement. Do we consider this difference into consideration on fasting deficit replacement? This is the study in women under gynecological surgery, and they found that the blood volume is normal after preoperative overnight fasting. So, fasting deficit replacement has not been considered as essential as it used to be in the past. I come back to this slide again. The next question is the ongoing loss. This part is composed of third space loss, which is does this rarely occur or not? I don't have time to mention about this third space loss and blood losses. However, there's no doubt that this ongoing loss should be replaced by isotonic solution. What about the maintenance fluid? Should we consider hypotonic or isotonic solution? This slide shows a well-known Holiday Seeger work in 1957 on fluid and sodium requirement in children. Firstly, the caloric expenditure in hospitalized children was calculated by averaging the basal metabolic rate and children with normal activity. They assume that the caloric expenditure in hospitalization is in the middle between basal metabolic rate and children with normal activities. Can this energy requirement be applied in children during anesthesia? I have no answer. Secondly, since the water losses are the function of caloric expenditure, then fluid requirement can be determined by insensible water loss, renal loss, and water of oxidation. Then we come up with the fluid requirement of 100 ml per 100 in 24 hours. These are very complicated calculations and assumptions, such as how we assume that water from oxidation is 16.7 ml per 100 calorie per 24 hours. I cannot find the reference for this because this was quite a long time ago. It's 1947. Again, I have no answer for this assumption. And then sodium requirement was derived from the midpoint between sodium concentration in human milk and the sodium recommendation in adult. This is another assumption. When these assumptions come to the recommend maintenance fluid and total sodium requirement were combined, this will give a sodium concentration of 30 milliequivalent per liters of sodium. This come up with a popular solution, 4% dextrose in 1/5 saline or 5% dextrose solution in 1/5 saline in Thailand. What happened if administer hypotonic solution? Since 1966, there has been several reports on postoperative hyponatremia in adults and in children. The cause of postoperative hyponatremia is the release of antidiuretic hormones. Antidiuretic hormones or arginine vasopressin is synthesized in the hypothalamus and stored in the posterior pituitary gland. This ADH is responsible for water reabsorption across the renal collecting ducts. ADH is crucial for maintenance of osmotic homeostasis. That when there is change in plasma osmolality, this will stimulate osmoreceptor in the hypothalamus and release antidiuretic hormone and regulated plasma osmolality. However, there are non-osmotic stimulation of antidiuretic hormones. During this process, the body regulates the blood volume rather than osmolality. Water was reabsorbed despite low plasma osmolality. We call this phenomenon as non-osmotic causes of antidiuretic hormone secretion. These are such conditions: hypovolemia, pain, stress, certain drug, CNS infection, and some metabolic endocrine disorder. This non-osmotic stimulation of antidiuretic hormone is responsible for postoperative hyponatremia. How to prevent postoperative hyponatremia? There are two debated rationales to prevent this postoperative hyponatremia. One, firstly, is increase salt. The second is decrease water. Fluid restriction regimen was supported by Holiday and Seeger, the same group as in 1957, but they published a paper in 2004. They state that in special group of children where antidiuretic hormone is elevated, such as brain injury, drug, and pain. In this situation, the antidiuretic hormone is high in the absence of hypovolemia and hyperosmolality. So in this situation, the maintenance fluid should be half average of 50 ml per 100 kilocalorie per day. So this comes such as summarized in 6 kilo babies, the fluid maintenance should be at 6 ml per kilogram per 6 ml per hours. So in this instance, from 4-to-1 formula should be reduced to 2-1.5 formula. However, both restrict fluid regimen or increased salt regimen have some debates. If we administer hypotonic solution, hyponatremia still exists, and there are meta-analysis and RCT trial demonstrated that hyponatremia is related to fluid type, not the fluid rate. Also, if we administer isotonic solutions, there are still hyponatremia is still exists. This is what we call desalination process. This is caused by rapid administration of fluid and rapid expansion of extracellular fluid. This will increase in natric diuretic peptide and decrease aldosterone levels. The kidney will excrete more sodium, and with a high antidiuretic hormones, this will cause hyponatremia. And also, if we administer isotonic solution, especially in normal saline, there will be some risk of hypernatremia. These are the studies regarding intravenous hypotonic versus isotonic solution for maintenance in children. Jung and group in 2006 published a meta-analysis and demonstrated that hypotonic administration was associated with hyponatremia in hospitalized children. However, this study was include medical patients with gastroenteritis as well as surgical patients. This is another RCT study on postoperative hyponatremia. This study also confirmed that fluid type, not the rate, are associated with hyponatremia. This is a Cochrane review by McNabb and group in 2014. Hypotonic administration was associated with hyponatremia, and isotonic administration can reduce the risk of hyponatremia to 50% with a relative risk ratio of 0.48. And subgroup analysis in surgical patients demonstrated the same result. When the rate of fluid administration was taken into consideration, full maintenance rate and in a restrict rate have the same result. There is also similar risk ratio for postoperative hyponatremia, but with a wider range of confidence in restrict group. What about in normal? In conclusion, maintenance fluid during anesthesia may be less than 4:1 formula, and hyponatremia correlated with the fluid type, the fluid rate. What about in normal practice? In UK and in Thailand, there's a survey. Up to 90% of anesthesiologists still administer hypotonic glucose solution for maintenance intraoperatively. This was done in 2006 and 2011. However, this amount of fluid is less important in major surgery rather than minor surgery because this is so small as compared with ongoing losses and blood loss replacement. Moreover, the maintenance fluid was less than it used to be in the past. So, and please don't forget the glucose background infusion of 120 up to 300 milligram per kilogram per hour. In conclusion, I would like to summarize my talk as a little bit sweet but fully salted. Thank you very much for your kind attention.
Thank you, Dr. Ruyan, for your very interesting and informative talk. Also, thank you for the audience, since we are receiving many questions by now, which make the discussion after the webinar will be very vivid. Now, I want to introduce you Dr. Yoon Hee Kim. She is a clinical assistant professor at Seoul National University Hospital in Korea. And she is interested in hemodynamic monitoring and ultrasound guided procedures in pediatric anesthesia. And she will tell us about the fluid responsiveness in the pediatric population. Welcome, Dr. Kim.
me. Good afternoon, ladies and gentlemen. I'm Eunhee Kim from Seoul National University Hospital. I'm very honored to give a lecture in ASPA-FLEX webinar. Today, I'd like to give a lecture on fluid responsiveness in the pediatric population. In my lecture, I'm going to introduce a case presenting intraoperative hypotension. Then I will explain about physiology of fluid responsiveness. Lastly, I will introduce potential parameters of predicting fluid responsiveness in pediatric population based on researches in my center. First of all, now I'll show you a case in the operating room. This 4-month-old girl who was planned to undergoing abdominal surgery, the Kasai operation for biliary atresia. She weighed 6 kilograms and her systolic and diastolic blood pressure and rest was 95 and 65 milliliter mercury. Anesthesia was induced using thiopentasodium and maintained with the continuous infusion of sevoflurane and lamivudine. We placed the invasive atrial line and central venous catheter. As you saw from this video clip, at the time of operation started, her systolic blood pressure maintained 85 to 90s. But about an hour later, the systolic blood pressure lowered slowly to 70s. The central venous pressure also lowered. We examined the operation field, but the blood loss was not obvious. Atrial blood gas analysis showed within normal range, so we considered topical blood loss from the open abdomen. Then we tried volume expansion. We gave her plasma solution 10 ml per case, but the systolic pressure did not recover to baseline state. So we gave her plasma solution one more time. But the volume expansion increased systolic blood pressure only transiently. The blood pressure lowered again and again. Should we give more fluid in this patient? We decided to increase cardiac output with inotropic agent dopamine continuous infusion. Dopamine continuous infusion increases the systolic blood pressure to 80s. This girl showed stable vital signs for a while, but at the end of operation, the blood pressure lowered again. Should we give more fluid in this patient or add inotropic agent? We gave her fluid bolus and the inotropic agent also. When the patient have acute circulatory failure, volume expansion is usually considered as the first line of therapy. However, as you saw from our case, the intravascular volume expansion did not always increase cardiac output. Uncorrected hypovolemia may affect the tissue oxygenation, leading to organ dysfunction and death. But fluid bolus administration itself may exacerbate tissue and end-organ edema. The fluid expansion as a supportive therapy, the FEAST trial showed large volume fluid resuscitation and a positive cumulative net balance have been associated with worsening renal function, acute lung injury, prolonged intensive care unit stay, and even mortality. In pediatric studies examining fluid responsiveness, roughly 50% of children responded to intravascular volume expansion. Therefore, predicting fluid responsiveness is important when managing critically ill patients. Fluid responsiveness is defined as an increase in cardiac output after the administration of a fluid challenge. Will cardiac output increase with fluid loading in all patients? Determining which patient will be fluid responsiveness is really challenging. All patients are not the same. When you give a fluid to patient, presuming that the patient lies on the steep portion of Frankenstein curve, it will increase the stroke volume and cardiac output. This is fluid responsiveness. On the other side, same patient in the flat line of Frankenstein curve, giving more fluid did not increase stroke volume, hence cardiac output. This patient is not fluid responsiveness. How can you predict fluid responsiveness? Many studies recommend using dynamic parameters over static parameters for predicting fluid responsiveness. The static parameters are referred to single measurement in time, and they tend to be less predictive of fluid responsiveness or not predictive of fluid responsiveness, and those methods include central venous pressure. Dynamic parameters refer to change in certain parameters over time, and they tend to be more predictive of fluid responsiveness. Most of these parameters rely on cardiopulmonary interaction. Those dynamic parameters such as PPV, pulse pressure variation, SPV, systolic pressure variation, have been found to be quite predictive of fluid responsiveness in others. However, those pressure-based dynamic parameters are unable to predict fluid responsiveness in the pediatric population. The reasons for the discrepancies in the reliability of dynamic parameters for predicting fluid responsiveness between children and adults are complex and multifactorial. Currently, only the respiratory variation of aortic blood flow peak velocity has been proved to be predictive. However, it has a limited ability in some clinical situations. For obtaining the respiratory variation of the aortic blood flow peak velocity, transthoracic echocardiography or transesophageal echocardiography is needed. But transesophageal echocardiography has some problems associated with its probe, especially in infants. Insertion of the TEE probe is relatively invasive. It can compress the left main bronchus and cause respiratory problem in small infants. Sometimes the TEE probe is not available. If the surgical field is close to the chest, the transthoracic echocardiography also cannot be applied. These findings underline the need for easily applicable and more reliable predictors of fluid responsiveness. The last part of my lecture, I will introduce the potential predictors of fluid responsiveness based on the researches in my center. Prediction of fluid responsiveness is in pediatric patients has been a many research topic in my research team. Several parameters for assessing fluid responsiveness have been described. I will introduce three of them today. Firstly, I will introduce an article published in Anaesthesiology titled Respiratory Variation of Internal Carotid Artery Blood Flow Peak Velocity Measured by Transfontanel Ultrasound to Predict Fluid Responsiveness in Infants. Cranial sonography is a widely used point-of-care modality in infants with advantages of accuracy, cost-effectiveness, and easy applicability at the bedside. As the antennae fontanelle remains open until 12 months of age, color Doppler ultrasound can easily visualize the vascular structure, including the basilar artery, internal carotid artery, anterior and cerebral arteries, which form the circle of Willis. A portable ultrasound device with high-frequency transducers can provide high-resolution imaging of the cranium. The internal carotid artery is a terminal branch of the common carotid artery, can be visualized using transfontanel ultrasound. Internal carotid artery blood flow direction is parallel to the Doppler beam of isolation from the anterior fontanelle, preserved without angle adjustment. Accordingly, the accuracy of measurement can be improved. Therefore, the Antonio Fontana is an optimal site for the flow examination of the internal carotid artery blood flow. When you measure the cerebral blood flow velocity using transspontaneal ultrasonography, we observed respiratory variation in internal carotid artery blood flow peak velocity, like stroke volume variation. So, we designed this study to evaluate the potential role of point-of-care transspontaneal ultrasonography for predicting fluid responsiveness in the pediatric cardiac patient. This is the study protocol. At the completion of sternum closure, we changed the tidal volume to 10 ml per kg. Then we measured the respiratory variation of the internal carotid artery blood flow peak velocity and respiratory variation of aorta blood flow peak velocity, PPV, CVP, and stroke volume. Then we administered 10 ml per kg crystalloid over 10 minutes. After that, we measured these parameters again and stroke volume. Fluid responsiveness is defined as more than 15% increase in stroke volume index after the administration of a 10 ml per kg fluid challenge. 30 infants, mean weight of 5 kg, undergoing ASD or VSD closure were included in the study. Of them, 17 patients were increased stroke volume index after fluid administration. We evaluated the predictive ability of fluid responsiveness by analyzing the AUC of the ROC curve. The respiratory variation of the internal carotid artery blood flow peak velocity can predict an increase in stroke volume in response to intravenous volume expansion. The area under the ROC curve was 0.83 and it was similar with that of aorta. From now on, I will introduce another article titled "The Role of TFA1 Adhesive Forehead Sensors in Predicting Fluid Responsiveness in Anesthetized Children." It was published last year in the European Journal of Anaesthesiology. In this study, we evaluated the predicting ability of fluid forehead sensors in predicting fluid responsiveness in children. This is the forehead TFA1 forehead sensor. This sensor designed to monitor oxygen saturation at forehead. The forehead site is less susceptible to peripheral perfusion change, and in a study comparing response rate, forehead sensors were found to have a faster detection of desaturation and resaturation. Also, forehead sensors offer easy access during surgery, exercitation, and in patients with finger deformities. This is the study protocol. During the surgery, we changed the tidal volume to 10 ml per kg. Then we measured the respiratory variation of the aortic blood flow peak velocity, PVI at the forehead, and PVI at the finger, and stroke volume. And we administered 10 ml per kg crystalloid over 10 minutes. After that, we measured these parameters again and stroke volume. 30 children, mean age of 4 years old, undergoing general anesthesia were included in the study. Of them, 17 patients were increased stroke volume after fluid administration. The AUC of ROC curve of the forehead sensor was 0.81. It was similar with that of the finger. The forehead sensor, although not superior to the finger sensor, is a reliable alternative for predicting fluid responsiveness in this patient. Lastly, I show the recently published article titled "The Prediction of Fluid Responsiveness Using Lung Recruitment Maneuver in Pediatric Patients Receiving Lung Protective Ventilation." Recently, lung protective ventilation is widely used in pediatric anesthesia, but the ability of dynamic parameters of fluid responsiveness is reduced with lung protective ventilation strategy with low tidal volume. In the situation where lung protective ventilation is widely used in pediatric anesthesia, how can you better predict fluid responsiveness? The lung recruitment maneuver, which is one of the components of lung protective ventilation, possibly enhances the parameter's ability to predict fluid responsiveness by simulating the hypovolemic condition. Lung recruitment maneuver sustains an increase in intrathoracic pressure and induces an increase in the right ventricular effluent load and a decrease in both ventricles preload. This change can decrease the stroke volume. And lung recruitment maneuver induces the hypovolemic condition, and this result is more pronounced in hypovolemic patients. Therefore, we hypothesized that lung recruitment maneuver would improve dynamic parameters' predictive power for fluid responsiveness. This figure shows our study's protocol. Basically, all patients were provided with lung protective volume controlled ventilation. Before we applying lung recruitment maneuver, baseline parameters of respiratory variation of platelet demography, POP, PPV, PVI, and cardiac index were measured. And lung recruitment maneuver was applied with continuous inspiratory pressure of 25 cm water for 20 seconds. After applying lung recruitment maneuver, the lung protective ventilation resumed and lung recruitment maneuver induced parameters was recorded. Following these procedures, patients given crystalloid 10 ml per case for 10 minutes. At the end of volume loading, we measured the cardiac index again. Finally, I will explain the result of the study. The left graph is the ROC curve of the baseline predictors, and the right one is the ROC curve of the lung recruitment maneuver induced predictors. Of the four variables analyzed, PVI was able to significantly predict fluid responsiveness both before and after lung recruitment maneuver. And contrary to our expectation, lung recruitment maneuver did not make a difference in predictive ability for all parameters. We concluded that the PVI is effective in predicting fluid responsiveness in pediatric patients with lung protective ventilation. However, the lung recruitment maneuver did not improve the ability of the other dynamic parameters to predicting fluid responsiveness in pediatric patients. There are several other potential parameters for predicting fluid responsiveness. Increase in diastolic blood pressure induced by liver compression, the passive regulating maneuver, NICOM, inferior vena cava diameter, can be helpful in identifying patients whose cardiac index might increase with fluid resuscitation. However, all these parameters also has its own limitation. More studies on potential parameters are required. Last but most important one is the effect of predicting fluid responsiveness on the clinical outcome. Can the prediction of fluid responsiveness improve the clinical outcome in the pediatric population? I'm not sure about this. Further randomized controlled trials are required. In summary, only half of children responded to intravascular volume expansion. The remainder received none of the benefit of fluid administration. But prediction of fluid responsiveness is difficult in the pediatric patient. Currently, respiratory variation of the aortic blood flow peak velocity was the only variable to reliably predict fluid responsiveness in children. Several potential parameters can be useful in clinical situations. Further research on the clinical outcomes are required. This is the end of my presentation. I hope you stay healthy during the corona outbreak. Thank you for your attention.
Thank you, Dr. Kim. It was a very nice speech, and congratulations for all your studies. Now we have our last speaker. She's Duygu Kara. She's an associate professor and works at Aydın Adnan Menderes University in Aydın, Turkey. She is interested in pediatric anesthesia, neonatal anesthesia, and pediatric sedation as well. And now she will try to clear our minds what we have in hand for monitoring during pediatric fluid resuscitation and therapy. Hi, Duygu Kara. We welcome you.
Hello, everyone. Thank you, Dr. Serpil, for your kind introduction. This is my little girl. She's 5 years old. She has just started to learn English. Last night, I was very anxious about my presentation, and in English, she said to me, "Mommy, don't worry. Only tell them, how are you today? I am fine, I am happy." So I hope you are fine and okay in these pandemic days. Today, my topic is what we have in hand for monitoring during perioperative pediatric fluid therapy. We all know that children are not small adults. Although the general principles in intravenous therapy are similar between adults and children, there are some additional factors that should be considered in dealing with pediatric patients. Perioperative fluid management in children should be based on physiology and the maintenance of the patient's hemostasis. And also, errors in perioperative fluid management in children may lead to serious complications and a negative outcome. The composition, type, and monitorization of fluid therapy during pediatric anesthesia have been subjects of debates for decades. We think, is there really appropriate monitoring for children? In fact, the most commonly used technologies in adults are not yet designed for children. Secondly, the children have wide spectrum of age, size, and weight. Also, their vascular access can be challenging, and their hemodynamic data is significantly lower than adults. Hemodynamic monitoring is classified into 3 groups, such as non-invasive, minimally invasive, and invasive. Regardless of monitoring techniques, we should effectively plan preoperative and intraoperative fluid goals. The parameters used to assess fluid responsive are basically classified into 2 categories, such as static and dynamic parameters. Firstly, static parameters. We know that volume status was assessed on the basis of static monitoring parameters such as heart rate, arterial blood pressure, central venous pressure, and urine output, and also oral intake, weight changes, urine volume, and specific gravity, physical signs and symptoms of dehydration, and serum electrolytes are important too. If the child is dehydrated, what should we do? Dehydration is based on a person's physical signs and symptoms such as skin turgor, color of urine, low blood pressure, rapid heart rate, and sunken eyes. So we should obtain vital signs and obtain the children's weight, and also assess hydration level based on a combination of signs. Under anesthesia, we can see reduced skin turgor, dry mucous membranes, and altered respiratory pattern, sunken fontanelle, and decreased urinary frequency or volume. And in this table, you see the assessment of severity of dehydration. And now clinical parameters. Systolic blood pressure and heart rate are not very sensitive indicators for volume status, as they are affected by confounding factors like depth of anesthesia or surgical stimulations. Central venous pressure and pulmonary arterial wedge pressures are poor predictors of fluid responsiveness. They do not accurately measure the circulating blood volume or responsiveness to fluid challenge. Also, they don't demonstrate consistent correlation between values of COP and blood volume, either total or circulating blood volume. Now, mixed venous and central venous oxygen saturation. They are obtained periodically from pulmonary artery catheter or central venous catheter through blood gas analysis or continuously using a fiber optic catheter. They do not reflect accurate changes in tissue perfusion during the perioperative period, when regional perfusion and oxygen consumption may vary. We know that there is a relation between skin temperature and pulses and the percent of blood volume depletion. Tissue perfusion can be used as evidence of cardiac output. So, if perfusion is adequate, the skin temperature is warm all the way to the fingers and toes. So, if the skin temperature falls down, we can say that there is a volume depletion increasing. So, for example, if the child's trunk is warm and extremities become cold from axilla, we can say that there is a 15% of volume depletion. And now laboratory-based parameters. At first, hematocrit depletion, it can assess changes in the circulating part of the blood volume, ignoring a considerable non-circulating portion of the plasma. It does not reflect acute changes in volume status, and sometimes there is a lag between the timing of result and timing of the blood sampling. Oliguria is a commonly used general indicator of hypovolemia, but not a sufficient indication for fluid administration. Sometimes perioperative medication, anesthetic drugs, and techniques, as well as surgical technique and manipulation, may reduce urine output. As the color of urine gets darker, we know that there is a severe dehydration and your patient needs more fluids and maybe medical attention. Base deficit and serum lactate. Lactic acidosis can be a surrogate marker of reduced global tissue perfusion, and it is measured intermittently and do not immediately reflect acute changes. Also, base deficit is a surrogate for serum lactate and can be confounded by renal dysfunction and ketoacidosis. And now, dynamic parameters. Dynamic parameters reliably predict fluid responsiveness in adults, but they may be influenced by tidal volume and other ventilator settings, and also can be calculated through the direct arterial pressure trace. In children, heart-lung interaction or cardiopulmonary interaction are different than adults. Lung compliance, chest wall rigidity, airway resistance, expiratory rates, and tidal volumes may have different impacts on preload and afterload than adult patients. And now, parameters derived from blood pressure. They are systolic arterial pressure variation and pulse pressure variation. Arterial pressure raise is dependent on stroke volume and arterial elastance. And we know that arterial elastance in children is low. The pulse wave velocity increases non-linearly with age in arteries of arms and legs. So this non-linearity is due to change in both arterial wall thickness and change in elastance. And also, they may be affected by respiration, arterial compliance, and special physiological and anatomical structures. As I said before, arterial elastance in children is low. Considering that pressures transmitted by an increase in stroke volume may be partially absorbed, and these parameters are not found to be significant of fluid responsiveness in children between age 6 to 14 years of age. And also, arterial pressure-based variables were shown to be poorly predictive in fluid responsiveness in mechanically ventilated children. Considering that the predictive ability of pulse pressure variation is improved by increasing the tidal volume in adults, they try to show that predictive value of pulse pressure variation can be improved in children with increased tidal volumes. Parameters derived from non-invasive cardiac output monitoring are stroke volume variation and index stroke volume. And in these studies, they are found to be predictive in fluid responsiveness, especially in sedated and mechanically ventilated children under different surgeries. And on the other hand, some of the studies were found to be non-predictive in fluid responsiveness in pediatric patients. And now, parameters derived from PET tomography. They are generated by the blood volume change in the vessels of tissues, not by the pressure change. And they have different characteristics from pressure-associated parameters, influenced by stroke volume, arterial and venous distensibility, and the venous pressure of the sampling site. So, they are potential dynamic parameters for predicting fluid responsiveness. They can be influenced by peripheral perfusion, microcirculation, sampling site, and contact pressure of the probe. And also, they are measured at various sites, including the forehead, ear, and fingers. And also, predict fluid responsiveness in mechanically ventilated adults. And here, these parameters are found to be predictive in predicting fluid responsiveness in both ventilated children and adults, and found to be reliable predictors in the pediatric population. But on the other hand, again, there are some studies that PVI cannot predict fluid responsiveness. Parameters derived from ultrasound. At first, respiratory variation of aortic blood flow peak velocity is measured at the aortic annulus, or the left ventricular outflow tract, by using pulse wave Doppler with transthoracic or transesophageal echocardiography. And it is also a promising marker for optimization of perioperative fluid therapy. We know that flow or volume-dependent non-invasive variables are more promising than pressure-dependent invasive variables. They are not affected by high arterial confluence in children. So it better correlates with the cardiac index or the stroke volume index than other dynamic parameters. In this study, it's found to be a consistent predictor of fluid responsiveness in pediatric patients under mechanical ventilation. Respiratory variation of aortic blood flow peak velocity measured at the suprasternal notch can be measured using transthoracic echocardiography from the suprasternal notch view, and it is useful when access to the chest wall is limited during surgery. And respiratory variation of carotid artery blood flow peak velocity measured using the transfontanal approach. With this technique, the blood flow velocity of the several arteries of brain can be measured using transcranial Doppler. It is found to be predictive in fluid responsiveness and intracranial abnormalities and cerebral blood flow. Respiratory variations of inferior vena cava diameter are known to be predictive in fluid responsiveness in adults. We know that positive pressure ventilation has an influence on inferior vena cava diameter, and also measurement errors can easily occur in inferior vena cava diameter with a small diameter. There are, in these studies, again, this parameter is found to be a good indicator of fluid responsiveness in both adults and children. Also, in other studies, they are found to be poor predictors of fluid responsiveness in spontaneously ventilating children with sepsis. And also not found reliable method to predict fluid responsiveness. Echocardiography and Doppler assessment of ventricular function is not found useful tool to predict fluid responsiveness, as they need special expertise and training for the operator. And also, they may not be applicable in some surgical procedures, limiting its usefulness as routine practice. This technique is found to be useful to predict and follow expansion responsiveness in neonates and infants. And also, although it is simple and relatively non-invasive technique, unlike echocardiography, transesophageal Doppler is not found to be useful to detect fluid responsiveness in cardiac patients. And they do not well correlate with values measured using the thermodylation technique. And now, abdominal compression in this blood pressure change. Abdominal compression can increase the preload by pushing the blood volume to the heart, so possibly increasing the stroke volume. This technique was found to be predictive in fluid responsiveness in mechanically ventilated children, especially after cardiac surgeries, and in children aged lower than 8 years. And last technique, passive leg raising. It's found to be helpful in assessing the volume status in children, and they reliably predict the fluid responsiveness regardless of ventilation mode. As a conclusion, predicting fluid responsiveness is difficult in the pediatric population. Dynamic parameters are definitely better predictors of fluid therapy over static parameters, but many of us don't have these technologies. So it is important to be able to manage fluid therapy in children with clinical parameters. And of course, further researches are needed with this topic. Thank you.
Thank you very much, Dr. Kara. This is a very exciting and very confirmative talk. Dear audience and everyone, today we have a very good webinar about advances in pediatric perioperative fluid therapy and also especially the intraoperative fluid therapy. I believe that we have a lot of questions to our speaker. To preserve the time of today, I would like to hand over to our moderator for the question and answer. Maybe we can see more what's the audience look for and what kind of question that we should make clear with the audience, and we can find the advanced solution later on. Thank you very much. I will hand over to Felicia and Sapil for more questions.
Okay, we have received a number of questions, and we won't be able to answer all the questions because of time constraint. Some questions have been answered if you look at the Q&A, and some will be answered by the presenter and sent to your email. Okay, we start with simple ones. There's a question that asks, what is the ideal fluid for a healthy 2 to 8 years old coming for elective surgery? Okay, and the question will direct to Dr. Sunerat.
Oh, thank you very much. I think I will answer along with the Professor Lin Leung. The ideal solution for the kid 2 to 4 years old is the kid is healthy. Personally, I will go with non-glucose solution, balanced salt solution, and if the kids fast very long, I will replace a little bit of the fluid as a little bit bolus at the beginning of the anesthesia. And how about Professor Lin Leung? Are you giving any glucose to this patient?
There's two variables that we should consider. Firstly is the fasting time. If the fasting time is so short and we allow the children to drink glucose water, that means glucose solution is not necessary. And in this type of children, hypoglycemia is, the incidence of hypoglycemia is quite low. So maybe we don't need any glucose solutions. The other thing is the volume of fluid. It depends on the operation. So if just a hernia repair or circumcision, maybe we don't need any fluid administration at all. Or if a little bit major, we maybe give some fluid, glucose-free solutions if children don't fast quite a long time.
Okay, thank you. There's another question relating to daycare surgery. What is the optimal maintenance fluid for infants and children for daycare surgery? Any one of you?
Dr. Lin Leung.
I do it. Just daycare surgery. Daycare surgery is just a, that's mean a short procedure. I suppose to be such a hernia repair or circumcision repair. So that's come very similar to the first question. Maybe we don't need any fluid at all, or just a little bit of fluid, whatever. Maybe we need some glucose-free solution, or just a little bit of saline, just to when we need some medication and we flush with some saline, that should be enough for short procedure.
What about Dr. Sunarat? What's your view on that?
Yeah, I agree with Dr. Lin Leung, but I personally rather exam more for the preoperative fasting, especially in in my country, that the outside weather is sometimes it's very hot. Is it very hot and the kid lost a lot of sweat, and we take a long time to go home. So I some kind of will give some balance salt solution. And if the kid is very slim, as Professor Lin Leung, I will start a little bit of 1.5% glucose. But anyhow, it's very difficult to mix with 1.5 glucose in my country. Sometimes I will go with the 5% glucose and then go with the balanced salt solution.
Okay, I know that there are some anesthetists who do not give any IV fluid intraoperatively for short cases, and especially daycare surgery. For me, I would give some, because I feel that if you don't give anything, the child will get up feeling very thirsty and very distressed. So my opinion is I do give some, just to alleviate that thirst when they get up. Okay, I think it's an individual opinion. Okay, now.
How's about in Turkey? How's about in Turkey?
We usually give, but I know that some people don't give. What about Duygu? In your place, do you?
We usually give to
for short cases, for day case.
Yes, for short case. Mm-hmm.
How's about in Korea, Dr. Kim?
Do you give glucose with me? It did not give glucose solution routinely in their case.
Glucose solution or any solution?
What?
Glucose solution or
A
any
glucose solution. Glucose solution.
Okay.
Right. All right. There are a few questions about giving glucose solution. One question is, do you advise giving solution with dextrose for every pediatric patient or for preemie and neonate? Dr. Runro?
Oh, preemie and neonates is a very special group of children. Most studies doesn't include neonates and preemie in the study. So in this group, we need some glucose infusion. This is because they are at risk of hypoglycemia.
Okay, so how much glucose will you give in such patients?
This is very difficult to answer. To cover everything, we have to say that you just give glucose and monitor blood glucose accordingly. But maybe 300 approximate, in my slide is 120 up to 300 milligram per kilogram per hour. If in neonates and preemie, we can go to the upper end, about 300.
Yes. Sometimes it's more convenient. You just use either 5% dextrose or 10% dextrose that comes, with already prepared, rather than calculate, right?
If we give 5% dextrose according to original holiday cigar 421, it will come up with a 200. Maybe sometimes it's a bit low.
Okay. What about the experience of others?
For myself, when I work in United States, we go with the 1.5% glucose by adding 50% dextrose in the bottle of the brown salt solution. But when I came back to my country, it's hard to do that, and everyone just concerned that what I am going to do with the very complicated procedures. So I go with the 5% as Ajahn Lin Leung, and then we measure the blood glucose of the kids. But I just want to ask the panel that are we still using like a 5% glucose in the half strength solution, or we go with the 5% glucose in the balanced salt solution? How is the other panel? How's about in Turkey?
We use for neonates glucose solutions, but usually we mix them. We measure the glucose and then give the glucose solutions. How about your place?
In our clinic, the neonates come with their TPN solutions. We give them in their normal doses. And if the neonate needs more glucose, we then give these solutions. Additionally, in fact, at first, we usually use their TPN solutions with these neonates.
How about in Korea?
We usually serially measurement the glucose level. And after that, I will choose to keep it or not keeping the glucose solution based on the PS level.
Okay. I think we are coming out of time, so I want to ask some questions for Dr. Kim. They are asking about in children with closed anterior fontanelle, would PVI using a finger probe will be reliable in assessing fluid responsiveness in pediatric patients? What's your opinion?
A meta-analysis concluded that the PVI is a reliable predictor in the pediatric population. And also our study showed that PVI is a reliable predictor, but some other studies show that PVI is not predictive fluid responsiveness in pediatric patients. Discrepancies is based because of the peripheral perfusion, sampling site, or contact pressure will influence this result. So I think PVI is effective in some situations. So you have to, if you want to use the PVI, you have to consider the perfusion or sampling site or contact force or other inotropic agent also. And after that, it will be effectively predictively responsiveness.
Thank you. And also there's another interesting question. How do you predict fluid response in thoracoscopic surgeries? Kim.
Oh, yes,
Kim.
but until now, there is no study in thoracoscopic pediatric patients. The dynamic variables rely on the cardiopulmonary interaction. So the thoracoscopic surgery impressed the predictive ability of dynamic parameters. I think there is more studies are needed in this situation.
Thank you. Thank you. And I think we will be closing with this question. What would be the most clinically feasible and reliable dynamic parameter in clinical situation, either in operating rooms or in ICU, if we don't have transesophageal TT or T?
It is difficult
Dr.
to
Kara and
answer.
Dr. Kim and all the panelists.
For me, it's difficult to answer. In research, the respiratory variation of
Skin
air
temperature is very important.
What?
Especially,
Temperature.
skin temperature is really important parameter. I think we can say that an easy and cheap method, if you don't have these monitors, blood pressure, heart rate, clinical parameters are really important. And also skin temperature is really important.
Both core and peripheral, you mean?
Yes.
Yeah, I agree with Dr. Kara. Sometimes the too sophisticated for the pediatric patient is difficult to do. For personally, I like to go the clinical. I like to touch the pediatric patient hand and toe temperature and see the capillary feel. And the worst thing is that if we see the mottling in the skin, that is the worst situation. I personally sometimes, apart from the PPV that we can see in the pediatric patient or recruitment to see when we use the low tidal volume, uh, I did the thoracic echo with the small probe because a TEE in the pediatric population, it's hard to find a small probe except we do the open heart surgery. So we do the thoracic, and sometimes with the orthopedic patients, we do the subcostal view. That is need a specialized. And if I cannot just anything, I will try with the fluid challenge test, like 3 to 5 cc per kilo carefully and see the response. That I did it sometimes. How อาจารย์ลื่นเริง what's your opinion?
You are muted.
Oh, sorry. I think the most important is clinical assessment, frequent clinical assessment, like the Professor Sunira said, capillary perfusions and some sort of blood pressure and heart rate. Basic assessment is essential. Thank you.
Thank you.
And and the other thing is that if the kid is cold, we need to warm the kids. And when you warm the kids, sometimes they have the vasodilate in the peripheral perfusion. They might need some more fluid. Personally, I like to warm the kid either with the forced air warmer or maybe cover or wrap the kids. That is very important, especially in the preemie and neonate patients.
Thank you. And there is one more, which non-invasive monitoring gives the most accurate results in pediatric fluid resuscitation? I think for all panelists.
Maybe Dr. Kim first.
Non-invasive resuscitation. Maybe clinical assessment.
You know, how about Dr. Kara?
I think clinical parameters, again, I say, are really important for pediatric fluid therapies than invasive variables.
By now. maybe they are improving, and so we will match the clinical ones with the invasive ones. But if we don't have, our
Any
senses are
monitors.
watching the patient is very vital. Watching and being there, touching the patient,
Yes.
knowing how long the baby was fasting, which fluids is he taking, they're all effects.
How's Ajahn Lin Leung?
Any more
What's your
any
opinion?
suggestions?
You are muted again.
Muted.
You are muted.
So what was the question? I'm answering the Q&A session.
Yeah, go ahead.
The non-invasive monitoring, which is most accurate if in pediatric fluid optimization. The non-invasive monitorization, the most accurate results.
Wow. This is very difficult.
Pediatric anesthetist.
Clinical assessment. Frequent clinical assessment.
Yeah, I
Yes.
agree with the frequent clinical assessment, especially when we
Yes.
palpate the peripheral pulse and capillary field. And when the kid is good, everything will be good. And when the kid's crying, I think that's a good thing also. And the other thing that sometimes I look for is the pulse oximetry. That if it's a good pulse coming back, that might present the good peripheral perfusion also.
And they are asking about how do we warm the fluids, warming the IV set or warming the fluid?
Whatever.
Whatever.
What do you?
Because the kid sometimes the set is very long. So sometimes if you go with the slow drips of the patient, it will warm by itself, except the operating room is very cold. That's why sometimes I warm the from the tubing, both the tubing and the IV fluid bag also, both of them.
Dr. Nikki, I think we have to close now. We are still having many questions, but they will be answered afterwards with personal emails, and they can find them at the website as well.
Thank you very much.
Thank you for all the speakers and for the audience.
Thank you very much, all our speakers. I know we all work very hard for this fluid webinar, and I'd like to thank both of our moderator Felicia, Sopel, and most of all is Vivian, who is our IT. So please remember that the certificate of attendance will be automatically sent to all the audience after you send us the web surveys. And at this time, I would like to announce for the next of our next webinar. Can I have the slide of the next webinar that will be about anesthesia outside of the operating room? This one that will be in the ASPA-9, March 21st, 5 p.m. Singapore time. Is the NORA for kids perspective on providing better anesthesia for children outside the operating room. This is also another important issue. This will be presented by Dr. Lim, Suan Lin, Dr. Luke To, Dr. Sanjay, uh, and Dr. C. Ketan Sudarawan. I'm not sure I pronounce it right, and Vivian also. That I hope this will be another good ASPA webinar also. So it will be on March 21st, 2021. And if any question, you can directly to our website, and we try to invite to our speaker and try to answer as much as we can to make sure that the audience understand what we talking. And also, you can go to our website to see this talking. Uh, I think about 2 or 3 weeks after this talk on our website. Thank you very much, and I'd like to close this webinar, and I'd like to thank all our speakers, our moderator, and most of all, Vivian. Thank you very much again. Thank you.
Thank you.